Our next lecture is about endometriosis. I will talk about definition and introduction, prevalence, pathogenesis, symptoms, clinical evaluation, management, and we'll have some conclusion. Why we need to talk about endometriosis? Because it's a very common disease. It affects 10 to 15% of women at reproductive age. Worldwide, about 176 million women are affected. 20 to 50% of patients who have subfertility or infertility are usually due to endometriosis. Up to 80% of women with pelvic pain is from endometriosis. 20% of the cases are asymptomatic, and 1/3 of the cases suffer from the severe form of the endometriosis, which is called deep infiltrating endometriosis. So what's endometriosis? Basically, it's endometrial tissue outside the uterine cavity. It's a chronic disease. Etiology is uncertain and affect predominantly women in reproductive age. The most common site of endometriosis is uterosacral ligaments and ovaries. Ovarian endometriosis might lead to formation of the cyst, which is full by old blood, and this cyst is usually called chocolate cyst. Occasionally, endometriosis affect other sites like vagina, umbilicus, abdominal wall, scar, bladder, rectum, even lungs. It's more common in women of higher socioeconomic class. In the past, we have two researchers who describe the endometriosis in two types. One is called Cullen syndrome, and the other one is Samson syndrome. Basically, Samson described the simple form of the disease, or the earliest stages of the disease of the endometriosis, while Cullen syndrome referred to the severe endometriosis, stage 3 and 4. So Simpson was talking about superficial endometriosis. It usually causes mild to moderate symptoms. There's no associated complications. It's superficial. You can treat it by medical means or surgery. Histology, you have endometrial-like glands and stroma. There's no malignancy. Cullen described the severe form, which usually have nodules. You have severe symptoms associated with complication like menstrual pain, locally invasive. It needs extensive surgery, and the histology usually showed fibromuscular hyperplasia or adenomyoma, and there is a possibility of malignant transformation. Theories on pathogenesis. Endometriosis always been an enigmatic disease. There's many theories, and no one theory in its own explain the whole spectrum of the disease. So the earliest theory was the activation of residual embryonic tissue that was described 1896, 1899. Other theory is Hoylemic metaplasia by Wanhoff and Meyer. This is also in 1898 and 1990. This basically state that the common sites of endometriosis we talk about, they have a common embryological origin, and that why at one stage these cells differentiate to this type of endometrium-like tissue. But it doesn't explain why you find disease in other places. So after that came lymphatic disseminations, which means that it's the endometrial tissue spread through lymphatic drains. Then retrograde menstruation. This is the most widely acceptable since 1927, which basically state that during menstruation, endometrial tissue go back through the fallopian tube and implanted in the pelvis. Hematogenic dissemination, this to explain a distant metastasis or distant endometriosis, like endometriosis in the lung or in other organs. Embryogenic origin, this is the most new one and the most logical one for me. The theory goes that you're born with endometriosis because these two researchers found endometriosis in embryos and in new infants, and they found it in the same percentage of the adults. It's about 10 to 15% of the samples they include in their research. So they come with this theory that you're born with endometriosis actually, but it remains inactive until you start having ovulation and your period started. So the production of estrogen stimulate the ectopic endometrium, but it takes years for full expression of the pictures. That's why if the period starts at the age of 13 or 14, it needs 6 to 10 years at least to develop to the full picture of symptoms or expression of the symptoms. That's why we find most of the cases in early 20s or 30s. We mentioned that. Now, what's the problems with endometriosis? First of all, it's common, 10 to 15% of the women. It affects large number of people worldwide, 176 million, as we said, 2 million in the UK. It's underfunded, it's underdiagnosis, and it's inadequately treated. These are the problems of endometriosis. There's usually delay in the diagnosis. The delay is usually between 6 and 9 years. The overall median delay is about 8 years. There's delay from symptoms experience to seeking medical help. There's delay from reporting the symptom with the primary care to being referred to secondary care, and there's delay from referral to diagnosis. Why there's a delay? On the patient level, there's delay because the patient thinks that these symptoms are normal. The most common symptoms of endometriosis is paining during cycle or before cycle, and they think this is just normal period pain. Other reason why there's a delay because they are reluctant to disclose symptoms due to embarrassment and fear. They feel shy to talk about these symptoms because it's pain during period mainly. Also, other symptoms of endometriosis is dyspareunia, painful intercourse. Again, they feel shy to talk about this. At the medical level, symptom normalized by medical staff. Again, some of the normal staff, when the patient complain about pain during the period, they think it's normal and they tell the patient it's normal. It's just period pain. Intermittent hormonal suppression of the symptoms. Any hormonal treatment which reduce the function of the ovary, it's usually controlled symptoms of endometriosis. That's why any type of hormonal treatment will delay the diagnosis. False negative investigation. The most important one is when you do a laparoscopy and you can't diagnose endometriosis because of lack of experience and people always look for one single picture of endometriosis, while the endometriosis can come or can be expressed with a wide variety of how the cells will look. Most people will only diagnose the endometriosis if they see a blue or bluish or dark color, discoloration of the lesion. While the lesion can be white, can be transparent, can be only pocket. It can be only thick lesions with filmy adhesions. All these other lesions usually not diagnosed as endometriosis by most of gynecologists, and that's the main reason of delaying diagnosis. How does it present? Pain and subfertility. Pain, either pain during a cycle, during intercourse, chronic pelvic pain, or dyschezia, pain during defecation, if you have endometriosis in the bowel. Or the other representation is infertility. When she has infertility and she ignores all the symptoms, if she has symptoms, and the endometriosis discovered during investigation for fertility. So the symptoms, on 80% of the patient you'll find dysmenorrhea. Up to 50% will have chronic pelvic pain. Up to 50% will have subfertility. Dyspareunia from 25 to 40%. Irregular cycle 10 to 20. Dysuria or hematuria 1 to 2%. Dyschezia 1 to 2%. And rectal bleeding less than 1%. So dysmenorrhea is the most common cause. Clinical evaluation. The pain of endometriosis usually a pain which has a pattern. Pattern mean it comes at the same time every period, either before or after or whenever. It's a cyclical pain. But the most common one is pain typically started before the period, and it eases during the phase of bleeding. Deep dyspareunia, especially if you have deposit in the vagina or the pouch of Douglas. Subfertility, rectal bleeding, hematuria if you have endometriosis in the bladder or rectum. Examination, most of the time you can't find anything during examination, but you have to look for masses. You can see a bluish discoloration of the cervix or the vagina. You might find a mass or a cyst in the abdomen. By manual examination, you might feel a nodule, a fixed uterus, tender uterus. You can feel the rectovaginal septum and feel something thick there. Uterus immobile, retroverted with extensive adhesion. Examination of the adnexia might reveal a mass. But as we said, you might not find anything, but you still can have endometriosis. Imaging, transvaginal ultrasound is very helpful in detecting the endometrioma, which is the cyst in the ovary. But if you have superficial disease, you must see it by ultrasound. MRI is good if you have peritoneal region in the bowel, if you want to see the extent of this lesion, or if you have pelvic mass and you see where which part of the pelvis it's involved. We might have high CA125, but this test has very low sensitivity. Laparoscopy is the gold standard diagnostic test for endometriosis. So you have to put a camera and see the endometriosis. Classification. The American Fertility Society has a scoring system which grade endometriosis to grade 1, 2, 3, and 4. Each lesion, according to the size and depth, it has a score. So you describe all the lesions, you put them, then you calculate the score. If you have 1 to 5, this is minimal. If you have 6 to 15, this is mild. If you have 16 to 40, it's moderate. If you have more than 40, is severe. Laparoscopic appearance of the peritoneal endometriosis. As you see, all these pictures are endometriosis. But most people will only look at the blue-black lesions, something like this lesion. Anything else, they don't consider it as endometriosis, while it can be a clear papule, red polypoid lesion, red flame lesions, powder burn lesions, brown lesions, white lesions, peritoneal pockets. All these are endometriosis. This is the typical blue, dark bluish lesions that most of the people only diagnose endometriosis if they see this, while they ignore most of the other cases. Indication for treatment. Usually patients come for treatment if they have pain or fertility, or in advanced or severe cases of endometriosis if they have ureteric obstruction or bowel obstruction. So how we manage endometriosis? The choice of treatment depends on the age of the patient, fertility plans, the severity of symptoms, the site of the disease. These are important. Treatment options are medical and surgical. The medical could be non-hormonal, without any hormones, which mainly non-steroidal, painkiller, or hormonal, anything which can suppress the function of the ovary. That will suppress also or calm down the endometriosis. Surgical can be laparoscopic or open. Non-hormonal treatment, simple analgesia. It's cheap, it's safe, and you might treat the symptoms. Disadvantage, it might mask, delay the further treatment, and allow disease progress. Hormonal treatment. The aim of the hormonal treatment is to cause atrophy of the ectopic endometrium by suppressing the ovarian function. Can use progestogens, combined oral contraceptives, Mirena coil, danazole or gestrinone, gonadotrophic releasing hormone agonist, plus minus feedback, add back HRT. Here progestogens is cheap and safe, but had these side effects: bloating, skin chafe, breast tenderness, weight gain, and contraceptive. Combined oral contraceptive pills, again cheap and relatively safe, but it has side effects. It is a contraception. It causes breakthrough bleeding, and it raises estrogen level. Danazole. Danazole, it has a massive or great androgenic side effects. Basically, it turns the female to male, voice changes, contraceptive, need to adjust dose to achieve amenorrhea. Maybe the only advantage is it increases the libido. GnRH agonist. Advantage, achieve very high post-estrogenic state and hence disease regression, can be used adjuvant to surgery. Disadvantage, it's expensive. It has limited duration of use, up to 6 months, marked hypoestrogenic side effects, and osteoporosis. So what medical treatments are the best? All the hormonal treatments probably have the equal efficacy, but the difference in the side effects. All the medical treatment are relatively contraceptive. and the disease recurs after cessation of treatment in the majority of the cases. Surgical options: you can have laser, vaporization, harmonic, diathermy, bipolar, unipolar, laparoscopy, laparotomy, excision, coagulation. Laparoscopic ablation and excision appear to be effective treatment for pain associated with endometriosis. Up to 70% of the women with mild to moderate disease report symptomatic improvement. Benefit appear to be more long-lasting with medical treatment. So if you have surgical treatment followed by medical treatment, the pain-free intervals will increase. Up to 90% of women will continue to report symptomatic relief after 1 year. GnRH agonists used postoperatively is significantly prolong the pain-free intervals. Laparoscopic treatment may also improve fertility. Endometrioma should be removed. The capsule of the endometrium should be removed, otherwise it will recur. Hysterectomy and bilateral salpingo-oophorectomy occasionally performed to alleviate symptoms when nothing else works. Endometriosis and infertility. As we said, up to 50% of patients with endometriosis have infertility. Why they have infertility? Because of distortion of the pelvic anatomy, because of adhesions, abnormal peritoneal and cellular function, ovulatory and endocrine abnormalities, impaired implantation. Management of endometriosis infertility: medical management is not indicated. Why? Because all the medical options cause contraception. Surgical treatment of mild to moderate disease improve the natural conception rate, and surgical treatment of severe endometriosis improve success at IVF. Adenomyosis. Adenomyosis is a subtype of endometriosis. Basically, it's endometriosis which you have endometrial tissue inside the muscle of the uterus, the myometrium. It occurs most often in multiparous women at the end of their reproductive age. So risk factors are high parity, vigorous curettage of the uterus, older age, usually at their 40s, presenting complaints usually heavy menstrual bleeding, progressive dysmenorrhea, and deep dyspareunia. Menorrhagia is the symptoms, the most common symptoms of adenomyosis. When you examine the patient with adenomyosis, you will feel the uterus is symmetrically enlarged and might be tender. This is adenomyosis. You see the spot of endometriosis inside the myometrium. Diagnosis is usually made by histology after you remove the uterus. MRI might be helpful. You might see the spot of endometriosis inside the myometrium. Treatment of adenomyosis usually doesn't respond to any medical treatment, and most of them require hysterectomy. This is adenomyosis. And that's all about endometriosis. Thank you.